Welcome to the AUA News Inside Track podcast, an official podcast of the American Urological Association. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.
I'm Dr. Andrew Harris, Chair of the American Urological Association's Quality Improvement and Patient Safety Committee. This is the fourth and final episode in our series on the Quality Improvement Project Guide. If you've been with us through episodes 1, 2, and 3, we have covered everything from understanding the guide itself, to testing small changes, to learning how to study and measure results. Today, in episode 4, we're going to bring it all together. We'll focus on what to do after you run your intervention, how to interpret your results, decide your next steps, and create a realistic plan for sustaining and even spreading successful changes. I'm here today with Dr. Julia Finkelstein, a pediatric urologist and Director of Safety, Quality, and Process Improvement for the Department of Urology at Boston Children's Hospital, and Dr. Bob Marcovich, a urologist and Associate Professor of Urology and Residency Program Director at University of Miami. Thank you both so much for being here.
Great to be here.
Thanks for having us.
So let's just get right into it. All right. Once we've completed our first cycles of testing, we've done the plan, we've done the do, and now we've done some studying, and now it's time, to get some action going. And a lot of people at this point are going to be saying, what do I do now? And I think that's where the framework of the 3 A's come in. How do you come to a decision if we should adapt, adopt, or abandon? And Julia, let's start with you if you can help us. How do we tackle this question?
Yeah. So, you're going to look at your data and you're going to see how your first cycle of testing went. You're going to think, hey, was this an awesome success? We want to make this a part of the way that we're doing everything everywhere. That's rare after the first cycle, but if you get lucky and that's the case, you're going to adopt that change. If maybe things didn't go so well, but they were still adequate, just need a little bit of tweaking, you might want to just modify it a bit and test it again. And that's probably the most common result of what you're going to see with initial testing. Then you're going to adapt that change, go back, make that change, and test it some more. And then the last day, if things were a total disaster, the change didn't go well, you need to go back to the drawing board, come up with another idea, you're going to abandon that change.
Yeah, I would echo that, as well as, a lot of times organically you can tell if something's working or not. So looking at data is important, but a lot of times you can tell just from how the process seems to be going. Is it working? Are the stakeholders all satisfied? Are there unforeseen roadblocks that have come up with the new process, or unforeseen consequences that need to be addressed? And sometimes these become very obvious, and because the process may be like peanut butter. So you just have to assess that way too.
Yeah, I think that's a good point. Beyond the data is also the people who are involved. So whether it's stakeholders or the front line, you want to also hear about how it went for them and get some of that qualitative data on top of just looking at the numbers.
Yeah, I appreciate those thoughts. I think, when you do this work, you come up with process metrics and you have outcome metrics. And a lot of times your hypothesis is if we alter the process metric, then we think that it will alter the outcome metric. But to your, one of the things that we're kind of talking about is sometimes your process metric might move, but your outcome metric doesn't. Sometimes by talking to the people, you might start to feel what other opportunities you might have had, or what other processes that you could have influenced that might hit that outcome metric. Or by talking to them, if your process metric didn't change, but they're feeling a difference, maybe you measured the wrong one, right? So it's a good opportunity to go back and look at, okay, people are feeling a change. What did we miss in measurement? So I appreciate those thoughts. I also appreciate you guys didn't ever say that we failed. And I appreciate that. We learned something. So even if we abandon, we still learned something. And then you can use that to go back and take a look at the next PDSA cycle. And so to expand on that a little bit, obviously not every project is going to be adopted right away. And both of you all mentioned some thoughts in this manner. So sometimes the most valuable lessons come from projects that had to be adapted or even abandoned. So can each of you, and we'll start with you, Bob, if you don't mind, can you share a story of a project you've worked on, or maybe the first approach didn't quite work out the way you thought it would, and then what'd y'all do next?
So yeah, I think looking back to early on in my QI days when I was just getting started and I didn't really have quite the full grasp of the process and the science behind it, we did a project where we had at our county hospital a TURBT quality reporting checklist. You want to report the standard stuff on the TURBTs, the size of the tumors, the number of the tumors, clinical stage, bimanual exam, etc. And we basically just kind of made it so that when the residents dictated their operative report, there was a checklist in the workroom where they went through that checklist and dictated that into their operative report. And it that worked well initially with the crew that got it started, but then as the residents changed over time, it sort of became less of a workable thing. And it would have been better, I think, in retrospect, to hardwire it into the system somehow. Make it a TURBT OpNote template that everyone has to use, or rather than having the checklist in the workroom, have it in the OR, have it up in the wall, have our nurses who, we work with the same set of nurses in the operating room all the time, have them sort of involved in making sure that that checklist is being gone through. So I think hardwiring things into the system and not relying as much as possible on human behavior or good intentions is important.
Yeah, I love that. That's just a phenomenal example of a little bit of drift that sometimes happen when processes rely on people a little too much, and we don't build the system to make it easy, even though it was a phenomenal effort by those who started it. So really appreciate that example, Julia.
Yeah, the first example that comes to my mind revolves a lot around the people as well. Um, we, our institution originally designed a direct to OR protocol for life-threatening neurosurgical emergencies or traumas that we have since modified to apply to our time-sensitive condition of testicular torsion. And you'd think it'd be perhaps easy to apply this process to our patients, but it actually was a big undertaking. And even 2 years in now, I think it's still been iterative and with adaptation, but defining sort of what's in scope, what do we need from the outside institution, all who needs to be on that phone call to have input into whether this can be a direct to OR transfer. So the emergency room, peri-op, or charge nurse, anesthesia, outside ER, a lot of different parties involved. And then the actual, even with them getting transported over, they bypass our emergency room. But for those life-threatening emergencies, they go straight directly into the OR, don't even stop in pre-op. And we're like, well, should they stop in pre-op for us and get consent there? There's each piece of the process we need to rethink, and we keep adapting over time, as well as because the people change. We have rotating residents who are in the mix, and we have to make sure that they're constantly informed when we have new faculty that we onboard, that they're aware of the process, that all attendings are have attending to an attending discussion um, to approve this. And so I'd say that it's like most projects that we get involved in, they're iterative. I wouldn't say it's failure, but there's always good learning to be had and to make it, better. I don't think in healthcare and in most of our projects we're ever going to get to perfect, but we can always work towards, doing better.
Yeah, I appreciate those thoughts. Yeah, what a wonderful opportunity for the patient to be able to take care of more quickly with you all working together. And so that continual iterative process, huge potential gains on the back end with that process. So that's really impressive. Thank you for sharing that. So once you reach the point of integrating an intervention into practice, you have to make sure the change is sustainable. So what do you think teams should focus on to maintain success over time and avoid slipping back in those old habits? Julia, you want to take this one first?
Sure. I'd say actually even before that time point, you could be thinking about sustainability, designing for sustainability right from the outset. So when you're designing your intervention and thinking about, the feasibility and the impact, you can be thinking about the likelihood of sustainability before you actually get to that part. But of course, once you do get to the intervention and you've implemented and, you've had some success, I think Bob spoke to it, but you would want to think about, like, is that intervention, that process hardwired into the system? So, if it's something that's for a forcing function in our health record system, like, that's going to live on forever. If it's not, then, you have to think about the different ways that the people can sustain it, whether that's through communication with the front line, with stakeholders, what that looks like, how you keep the momentum going, what resources are needed to keep that going. And also really important to decide how long you want to continue to monitor the process for until you're really convinced it's still working and it's sustainable. Because you don't want to stop looking at it too soon and have that drift.
Yeah, I think I would agree with all of that. And I think the most important thing is really just as much as possible hardwiring things into the process, and again taking the human variability and element out of it as much as possible. Not to say that there shouldn't be like human oversight or we shouldn't reassess the process, but just the process itself. If you can take out some of the variability or some of the reliance on human nature, then you're going to make it more sustainable. Um, hard stops as an example. Sometimes you can't go to the next process or the next part of the process without doing something, and that can be one way. But the caveat with that obviously is that can also make the entire process frustrating, and it may go overboard. So you have to be careful with that.
Yeah, I appreciate those thoughts. I think trying to keep an eye on the data over some sort of time period. In the beginning, we tend to monitor the data very closely on a daily, weekly, monthly basis, and then move on to something a little bit longer, like a quarterly or twice a year, and then annual. But being really careful not to just let it go away, because then we stop looking at it. And if it's not automated and it does have a people component, people change, people turn, move on to jobs, new positions, those things, and then we may miss the opportunity to continue that process. So just keeping an eye on those things. So I appreciate those thoughts there. So once you've seen success in your own setting, you might start thinking about, okay, let's go and start spreading through the hospital environment a little bit. And Julia, you talked about this a little bit earlier about how you all are trying to adapt the straight to the operating room process. What are some key things to consider when you're implementing the intervention in a different environment? Bob, you want to start with this one?
Sure. Yeah, I think there are a number of important factors. I think one big one is sort of the culture of the new environment. So, for instance, if you're going to go from, a process that you do in your surgical environment, and you're maybe going to take it into a medical type or a procedural type, the culture of that environment, is going to be important. Are those people as interested? Are the stakeholders in that environment? What are their priorities? What are their resources that might be available? And also, I think being open to the suggestions and to the concerns of the stakeholders in that environment that may differ somewhat from your own environment.
Yeah, I think so you spoke about spread. I think it's important to also think about scaling first. So depending upon what your project is and the degree of sort of which you've scaled it across the institution. So if you already started with just a small test of change and then, you get to the point of standardizing across all the areas internally before you jump ahead to that spread to outside organizations. Because the only way, aside from the culture and the stakeholders and everyone on the outside, that you're going to be able to really spread it is to make sure that you have, a proven sort of implementation pathway to get there.
Yeah, I appreciate those thoughts. Other things that one could consider as you start to think about growing, scaling, spreading work is also what resources you're going to need. And sometimes involving leadership may be helpful in some of those discussions, because in your process that you're working on, you may not need a lot of resources. But if you start to then apply that to, say, all the other surgical specialties, that might require a little bit, even if it's updating the medical record note templates. That's going to take some work. And how do you get those right people involved? So all great points to think about as you start to spread and scale a successful project. So I really want to thank the audience for their time and listening. I want to thank Dr. Finkelstein and Dr. Marcovich for their expertise. Thank you both so much for having this conversation today.
Thank you.
Thank you for having us.
That wraps up the fourth and final episode of our 4-part series on the QI Project Guide. We hope this series has given you both some practical tools and the inspiration to start or strengthen your own improvement work.
This has been an AUA News Inside Track podcast. Thanks for listening. For more episodes of this podcast, visit www.auanet.org/podcast.